Dear students, welcome back. In the previous session, we have discussed about the intrinsic finger musculature, and also in the previous sessions, we have discussed about the extrinsic finger extensors as well as extrinsic finger flexors also. Okay, now you people are able to know all the attachments of all these muscles. Yes, so now it is very easy to understand the extensor mechanism now. So the extensor mechanism of fingers consists of extensor expansion. So this extensor expansion is also called as extensor hood or dorsal aponeurosis. And this hood is associated with musculature. Okay. So the extensor mechanism of the fingers consists of extensor expansion, extensor hood or dorsal aponeurosis, and its associated musculature. Okay, now the extensor digitorum, the dorsal and volar interossei, and the lumbrical muscles all together form this extensor mechanism. The structure of the extensor mechanism of each finger is made up of with extensor digitorum tendon and its connective tissue expansions and fibers from the tendons of the interossei as well as the lumbricals. Okay, all together form this extensor mechanism structures. Okay, the extensor digitorum tendon passes under the extensor retinaculum of the wrist, which is protected at that level by synovial sheath. The tendon continues distally where it is not covered by any sheath. Okay, once the tendon continues distally without its sheaths, which is going to flattens to form an aponeurotic head. So all this forms this aponeurotic head. Okay, after that, so this hood is formed just distal to the MCP joint. So the hood is formed distal to the metacarpophalangeal joint. So this flattened hood is joined by the tendon fibers of the interossei muscles that arise from the sides of the metacarpals, and some interosseous fibers go deep to insert directly into the proximal phalanx. So that kind of attachment we have seen earlier, and after that this hood splits into 3 slips. So the hood now it is going to splits into 3 slips. Okay, where at the level of proximal to the head of the proximal phalanx. So at the level of proximal to the head of the proximal phalanx. Okay, and it is having one central band and 2 lateral bands. Okay, and out of these 3 segments, a central tendon which crosses the PIP, that is proximal interphalangeal joint, and inserts on the base of the middle phalanx, whereas the 2 lateral bands pass on either side of the central tendon, crosses the proximal joint, and again these 2 tendons will reunite to insert into a single terminal tendon on the distal phalanx. Okay, so this is the extension of this tendon. The central tendon and both the lateral bands receive contributing fibers from the interossei, with the radial lateral band also receiving the lumbrical muscle. So this lumbrical is also getting inserted to this bands. Okay, and also these lateral bands are interconnected dorsally. So now we are seeing this thing as a dorsal view. So dorsally these two tendons are interconnected by a triangular band of superficial fibers known as triangular ligament or transverse retinacular ligament. Okay, yes. The dorsal hood is also attached to the transverse metacarpal ligament at this level. The dorsal hood is also attached to the transverse metacarpal ligament, which helps prevent bowstringing of the extensor tendon. So with the addition of all these attachments, it is also having another attachment called as oblique retinacular ligament. So the oblique retinacular ligament we can see on the lateral aspect of the extensor mechanism of the finger. So this is the oblique retinacular ligament. So this oblique retinacular ligament attachment occurs, then the structure of extensor mechanism is complete. So these oblique retinacular ligaments arise from the sides of the first phalanx and from the digital tendon sheath that encases the long finger flexors. So the oblique retinacular ligament arises from the sides of the first phalanx and from the digital tendon sheaths, here digital tendon sheaths, which is covering this FDS and FDP. The oblique retinacular ligaments continue distally as slender bands to insert on the distal portion of the lateral bands. So that means normally this oblique retinacular ligament, which is present on the volar aspect, it comes towards the dorsal aspect and which is getting inserted with that of the lateral bands. Okay, so with this the entire structure of extensor mechanism is complete. Okay, now we will see how these structures influence at different joints. So influence of this extensor mechanism on metacarpophalangeal joint and PIP as well as DIP. Now first we will see the influence of this extensor mechanism on MCP joint function. Here this is the MCP joint function. At each MCP joint, the extensor tendon passes dorsal to the metacarpophalangeal joint axis. So the tendon is present dorsally to the MCP joint axis. So once the active contraction of this muscle creates tension on the hood. So what is happened? So once the contraction of this muscle happens, the tension is created on the hood. Okay, so once the pull of this muscle takes place, what happens? There is a pull of this extensor hood towards proximally over the MCP joint and extends the proximal phalanx. So which causes extension of the proximal phalanx. So here the proximal phalanx is present at this level. So which extends the proximal phalanx. Okay. The other active forces that are present of that are present in the extensor mechanism are the dorsal interosseous, volar interosseous and lumbrical muscles. Okay. Each of these muscles pass volar to the MCP joint. Normally, if you can see this interosseous and these lumbricals which are present on the volar aspect. So normally these muscles causes flexion at the MCP joint, and these muscles are also present to the volar aspect of the MCP joint. So, but it is not happening. Okay, but it is not happening. So, at the MCP joint axis, which creates the flexor force by this interosseous and lumbrical muscles, is not happening here. Why? Because when the extensor digitorum, interossei and lumbricals all together contract simultaneously, which causes metacarpophalangeal joint to extend, because the torque which is produced by the extensor digitorum tendon is greater than that of the lumbricals and the interossei muscles. So this is the thing happening at the level of MCP joint. So now we will see how this extensor mechanism which influence on the PIP, that is proximal interphalangeal joint. So if you see at this proximal interphalangeal joints, so the proximal interphalangeal joint, what are the structures crossed dorsally on the PIP? So the structures which are crossing at the PIP joint are, one is the central tendon, yes, this is the central tendon, and then two lateral bands, and if you see volarly, so this oblique retinacular ligament is also crossing this joint. So dorsally by the central tendon and the two lateral bands, volarly by the oblique retinacular ligaments. The structures which are crossing the PIP joint are central tendon and the lateral bands dorsally and volarly by the oblique retinacular ligaments. The extensor digitorum, that is the structural base of the extensor mechanism, and the interossei and lumbrical muscles that have attachment to the head as well as the lateral bands are each capable of producing at least some tension in the central tendon and lateral bands. So the ED as well as the interossei muscles and the lumbrical muscles which are attached to these bands are having capability to produce tension on the central tendon as well as the lateral bands because of its attachments to their bands. The extensor digitorum, interossei and lumbricals are therefore each capable of applying an extensor force at the PIP joint. How it takes place means, when the active contraction of the extensor digitorum alone cannot produce sufficient tension in the central tendon or lateral bands to overcome the passive forces of the long finger flexors at the IP joints. So just imagine that. So now we are dealing at proximal interphalangeal joints at this level. So if alone this contraction of this extensor digitorum cannot produce sufficient tension on these bands to produce or to cause extension of the PIP to overcome the passive flexor forces on the volar aspect. Okay, for this thing, some additional force is required now at this stage. So that forces are created by these lumbricals and the interossei muscles. Okay, so how this happening here? Yes, an active contraction of interossei or lumbrical muscle is capable of generating the active tension in the extensor mechanism necessary to extend the PIP joint. Okay, so these muscles which are attached to this lateral bands, okay, lateral bands and the central bands. So contraction of these muscles also pulls the bands and causes the extension of the PIP joint. Okay, so just think that, so what will happen? So these lateral bands are also attached to the distal interphalangeal, above the distal interphalangeal joints. So the pull of these muscles which causes the proximal interphalangeal joint extension will simultaneously causes extension at the distal interphalangeal joints. Okay, yes. Now we will see this extensor mechanism influence on distal interphalangeal joint separately. So the distal interphalangeal joint is tied to the proximal interphalangeal joint by both active and passive forces in such a way that distal interphalangeal extension and PIP extension are interdependent. When the PIP is actively extended, the DIP will also extend. Similarly, active DIP extension will always create extension at the PIP. So, when a force is applied to the extensor expansion by the interossei or lumbrical muscles, tension is created simultaneously on the more distal portion of the lateral bands and terminal tendon that cross the distal interphalangeal joints. The muscular extensor force on the lateral bands is assisted by the passive action of the oblique retinacular ligaments. So this oblique retinacular ligament is also assisting this action. Although it is present volarly, but it is crossing the distal interphalangeal joint dorsally. Okay. So the stretch on the ORLS at the proximal joint creates a pull on the ORLS insertion at the distal lateral bands and thus on the terminal tendon that lies dorsal to the DIP. So once the stretch occurs, so this causes some pull of this ORLS which creates tension. So this pull, what is happening? This pull creates the extension of the DIP is taking place here. Okay. So in this way the DIP joint is forced to extend simultaneously with the PIP joint as a result of the combined active and passive forces applied to the lateral bands and the terminal tendon. So here the active forces are created by the interossei muscles and the lumbricals. Okay, and the passive force which is created by this oblique retinacular ligament. This passive force is also assisting this DIP extensions. Okay, so once the DIP is extended, which simultaneously causes PIP extension. If PIP extension occurs, simultaneously DIP extension is also taking place. Okay, so this is about the extensor mechanism. Okay, so in this session we have discussed about the structure of the extensor mechanism, and extensor mechanism influence on the MCP joint, PIP joint, okay, as well as the DIP joints. So in the next session we are going to discuss about some studies or coupled actions of these DIP and PIP joints. Thank you.